Nurse Nook. So if you guys saw my Texas vlog video, you probably remember me talking a little bit about ENCC, which is the emergency nurse. Oh my gosh, I can never say that full thing. I don't know what it is about ENCC, but I can never say that full word. Anyways, the emergency nurse core curriculum course that my job sent me to, it was like a week and a half course that my job sent me to, and I told you guys a little bit about it and asked if you guys wanted me to do a video on it, and so many people responded. But then when I was trying to sit down and think of like a good video plan, I was trying to write things down, and I'm like, there is just way too much information just to do one video about it. I mean, it was like a week and a half long class, and I was just filled with so much information. So I'm like, there's no way I can just do one video. So I decided to make a series and call it the Emergency Nurse Crash Course, and give you guys a little bit of insight of what it is to be an emergency nurse and what is important to know as an emergency nurse. So the first video in the series is going to be the A through I trauma assessment. Now, what is this trauma assessment? This is your initial rapid assessment when your patient rolls through your doors. So 9 times out of 10, your trauma patients are going to be coming in through EMS. And a lot of this A through I trauma assessment is already going to be started in the fields, but that doesn't mean you skip some of the letters. You still want to go through every single part. The goal of this A through I assessment is to decrease mortality, and the way it's designed is to take care of what can kill somebody fastest first. So the A of the trauma assessment stands for airway and alertness, and also included in airway and alertness is C-spine immobilization. So let me take you through airway and alertness. What does it mean to have a patent airway, and how do you assess if your patient is alert? Very simple to check if your patient is alert. Are they verbal? Are they able to respond to you? If not, they are not alert. Can your patient open and protect their own airway? If not, open their airway, do a jaw thrust, and you always want to inspect the airway, make sure there's no foreign objects in there, no vomiting, no nothing of that sort. The reason why we intubate patients that aren't alert and unconscious and have a low Glasgow coma scale is because they cannot protect their own airway. If you see your patient is unconscious, they have a low GCS scale, which is a Glasgow coma scale. This is checking their neuro status. If they have a low scale, they are not able to protect their own airway, and we need to protect it for them, which most likely will lead to intubation. Like I said earlier, along with airway and alertness comes with C-spine immobilization. You want to immobilize the C-spine because you don't know if they have a spinal cord injury or what's going on there, and also stabilizing C-spine keeps their airway open because you don't know if there's anything protruding inside the airway, so you want to keep it straight, keep their jaw thrusted, and keep everything in line. You're most likely going to have a C-collar on, but how to hold C-spine, especially if you're log rolling a patient, you basically just want to hold firmly but gently, like right at the base of their neck, and just keep literally, hold on one second. So say this is your patient. You want to hold C-spine like this. You want it to be firm but gentle, so that way when you log roll your patient, you're going to keep everything in line, just like so. That was the A of the trauma assessment, and with every kind of assessment, your ABCs are always the most important, and stands for airway, breathing, and circulation. So those are the 3 most important things of the trauma assessment, but there's still D through I of the trauma assessment that are also super important, especially for your trauma patients. But definitely at the top of the list are your ABCs, and that is with every single patient you have. So the B of the trauma assessment stands for breathing and ventilation. With this, you want to listen to lung sounds, especially if your patient is intubated. You want to make sure you're hearing breath sounds bilaterally clear, because sometimes when your patients are intubated, the ET tube can sometimes go into one bronchiole and the other is not being perfused at all. So definitely check for equal bilateral breath sounds. Even if your patient is not intubated, they could possibly have a collapsed lung. So by hearing your breath sounds, if you hear breath sounds on one side and nothing on the other, that could indicate a collapsed lung. So that's why it's so important to auscultate. Along with that, you want to make sure the chest wall is moving symmetrically on both sides. Again, can be indicative of a collapsed lung. Always when your trauma patient's rolling, you want to make sure you throw some high flow oxygen on them just to make sure they're getting perfused and ventilated adequately. So the C stands for circulation. Also included in circulation is hemorrhage control. So this is where you want to make sure you have 2 IV accesses established, because you never know what your patient is going to need. You want to make sure you have large bore IVs, like 20, 18 preferably 18 and up. You need these accesses in case you need to give blood, if you need to give fluids, if you need to push meds. You need as many accesses as you can get. Also with the circulation, you want to check pulses. You want to check first starting off with central pulses like your femoral pulse, your carotid, and then you want to check radial, and then you want to check your pedal pulses. If you're not feeling pulses, you need to go ahead and start your basic life support, your CPR. You need to go ahead and get on it because you need to save this person's life. D stands for disability or neurologic status. This is where you want to assess their level of consciousness. Again, although you do this as soon as they come in, but here's where you want to reassess. Assess their pupils, assess their pupil size, their reaction to light. All of that will tell you about their neurologic status. It's also where you want to check for reflexes, see if their spinal cord is still intact, if they're able to move any extremities, try to tickle their feet and see if their feet will jolt back. This will give you some clues as to what type of injuries may be present with this patient. So the E stands for exposure. So this is where you want to get your trauma shears out and cut all of the patient's clothes off. You know, don't be shy about it. Don't be like, oh, what if this was their favorite pair of pants? Listen, I'm sure they're going to thank you for saving their life, and they're not going to care about their favorite pair of pants afterwards. It's so important to do this because this is where you need to assess for injuries. You might be missing a bullet hole wound, some bleeding going on. You need to expose this full patient and examine them head to toe and see what's going on. So the F stands for a full set of vitals and family. This is where you start wanting to think about, is the family present? Is there somebody we can communicate with? You want to, establish a liaison between the healthcare team and the family to make sure someone is keeping them updated. Because if you think about it, what if it was your loved one that was just in a car accident and was brought in, and you have no idea of their status, and you know they're in the room next door, and you see all these people coming out, but you have no idea what's going on? You want to keep your family updated, let them know what you're doing, let them know what the next steps are, and they could even give you consent for blood, consent for transfers. So it's very important to make sure you have communication with your family. And also with the F comes with full set of vitals. This is where you want to establish your full set of vitals, make sure you have blood pressure, heart rate, O2 on, and your temperature. You definitely want to have these things so that you can start trending your vitals. You have a baseline BP established and you notice it dropping, you know something's going on. This patient might be bleeding out. So that's why it's important to have a baseline so you can track if there's any changes with the patient. The G stands for get resuscitation adjuncts. And within the G is the LMNOP. This one is kind of long, bear with me. The L stands for lab study. So this is where you want to get your labs from, pull some blood from one of your 5,000 IVs that you started and send it off to the lab. It's not super critical like your ABCs to get lab results, but definitely these are going to come in handy throughout this person's care. It stands for monitor cardiac rhythm. Again, super important. If your patient is in VFib or VTAC, you're gonna want to know that. So make sure they're on a cardiac monitor. When my patients roll in, that's like one of the first things we do is throw them on a cardiac monitor so we can monitor their rhythm. N stands for nasogastric or orogastric tube insertion consideration. Some, depending on the doctor, some might want to do this ASAP, some a little bit later. This is the time usually that they would consider it. O stands for oxygenation and ventilation analysis. So see how your patient is perfusing. Do your little cap refill on their fingers or toes. Look at their skin color. See how their oxygen status is doing. Usually with your trauma patients, there's going to be a respiratory therapist at the head of the bed at all times, especially while the patient is unstable. But still, you still want to do your own assessment. Look at their color, look at their cap refill, and see how they're doing. P stands for pain assessment and pain management. So if your patient is alert and oriented at this time and they're a trauma patient, they're most likely going to be in a lot of pain. So this is where you want to get your Dilaudid, you want to get your morphine if their blood pressure is okay, of course, and manage their pain. So moving on to the H. H stands for history and head to toe. So history is where you want to talk to the family if the patient is not alert and oriented. If the patient is alert and oriented, you can ask for medical history, any surgical history, and of course get the story about what happened in the field that made this person a trauma patient. If the patient cannot give us this information, we can get it from EMS or the family members. For the head to toe part, you're gonna wanna make sure you inspect, auscultate, and palpate everything from the head to the toes. The last letter of the A through I assessment, which is obviously I, stands for inspect posterior surfaces. So this is where you want to log roll your patient and examine their back. And you want to inspect for any blood, edema, any deformities. You want to palpate for deformities. And this is where you would consider removing them from the spine board. Patients that are conscious and alert can tell you the spine board is extremely uncomfortable. So especially if your patient is alert, try to get them off that spine board as soon as they're cleared. So that is the end of the A through I assessment. Make sure you guys stay tuned for the next video in the series. Thanks so much for watching.